We welcome you to Infectious Insights, a case series designed to discuss challenges and offer solutions for difficult-to-treat gram-positive bacterial infections. If this patient had concomitant bacteremia, would that change how you approach this patient?
I think in some ways it would. One of the issues with this patient is, as we found out, it ended up being an MRSA infection. And the initial antibiotic was vancomycin, which was theoretically in the appropriate therapeutic range at the point that she decompensated further and went to the ICU. Unfortunately, vancomycin is a somewhat slowly cidal agent. It doesn't act as fast as some other drugs that are on the market. And with this patient, that drug, which would have been the active one of the two for the treatment of MRSA, was not sufficiently reining in the infection. So I would have looked and said, well, she's already been on this broad coverage for a couple of days, and she's clinically worsening. I likely would have started my transition to a different antibiotic a little bit sooner. And if there was a bacteremia, very likely as soon as I knew that a bacteremia was present, because I really want to be aggressive with bacteremia. One of the things we've learned over the years is that the idea of bacteremia being present for a prolonged amount of time isn't something that we should really tolerate. Back when I was in training, they used to talk about 7 days of Staph aureus bacteremia being typical, and it didn't bother people. In my day-to-day work, I worry about my patients if their bacteremia is persistent beyond a day or two, because that means that the bacteria are able to spread and go to metastatic and other sites within the body. You can have development of endocarditis or spinal infections, as an example. So I really want active and aggressive antibiotics to shut down that bacteremia as soon as possible.
Yes, definitely agree with you. The intensivist chose telavancin when the vancomycin and cefepime weren't working, and they knew that it was MRSA. However, many individuals would change to linezolid, but then there is this potential drug interaction between sertraline and linezolid. Is that serotonergic adverse effect something that you worry about in your patient population?
It's something that I consider. Again, this is one of these areas where the data has been evolving over time. When linezolid specifically came out, which is over 20 years ago now, there were big warnings about the use with serotonergic agents. But the data that's been collected over the last couple of decades shows that the rate of serotonin syndrome is actually really no different with patients that are on and off the majority of serotonergic agents with linezolid. The two big exceptions are methadone and citalopram, which can still have a little bit more of a risk when it comes to the co-administration with linezolid. We still continue to take it into account and try to limit our SSRI use concomitantly with linezolid, but the absolute risk associated with that is likely a little bit less than had previously been felt to be present.
This Infectious Insights series is brought to you by Cumberland Pharmaceuticals.